or all about spine pain. This is what I've done for the last several years. So it's kind of old hat to me with regards to what's going on. It's a great place for PAs to work because you get office experience, plus you get a lot of OR experience. So it's I've always enjoyed it and probably will be there the rest of my life. It is something that I don't care what you do in practice, you can do anything in practice. And probably at least once a day, you'll hear, you know, my back hurts, my neck hurts, you know, something's going on. So this is something that you'll be approached with every day, and sometimes you just got to figure out what you need to do next before you just send them off to the surgeon and you haven't done anything with regards to working them up and seeing what's going on. So insurance is getting extremely particular nowadays. So I mean, even ordering, you know, before you used to go, oh, you came in and oh, your back hurts, okay, let's go get an MRI. Doesn't happen anymore. You have to literally put together, you know, a huge note, list all their conservative therapy, and that they've been on NSAIDs for, you know, 2 to 6 months, and that they've been on conservative therapies, and they've been to physical therapy, and they've failed all of these things, and it all has to go to most insurance companies anymore before you're going to touch an MRI. So, you know, not only is it something that you have to deal with on a daily basis, but it becomes a lot of paperwork to deal with it. They actually, about 3 years ago or so, claimed spine pain an epidemic. They do epidemics on how many cases there are per year and how much it costs to society. And so we now know that, you know, not only certain diseases and things like that, but with even going into pain is now just gone crazy with regards to everything else that's going on. So, click through. There's too much. Okay, there we go. So when you look at spine pain with regards to what's going on, 5th most common presentation to your office, 85% of the population will at some point in their life complain of back pain. So when you look at that, that's a huge number of people that you will see. Now, that doesn't mean that everybody's going to go to the doctor because they have back pain, but you will see it a lot. You'll actually hear more presentation in females than males, but they're actually more prevalent in males than in females, but females will actually complain a little bit more. Usually midlife, you know, you know, spine pain is usually a degenerative issue, so when you're talking about that, it's usually somebody who's, you know, somewhere in their late 40s to early 60s is when you'll start seeing it. Most commonly seen, but not always, in people who have sedentary lifestyles. You know, they're not very active, they don't do very much, they don't go to the gym, that usually leads to, for most people, increased body habitus. So, you know, their BMI is, you know, I had a lady come in yesterday, his BMI was 62, and she wondered why her back hurt. You know, and they get very offended when you tell them, well, your back hurts because your BMI is 62, but you have to tell them, you know, what's going on. Manual labor, obviously people who work hard jobs and are lifting hard stuff, and you see it a lot in Oklahoma. You got a lot of oil people here. So the guys that are out in the oil fields all the time that are doing stuff come in hurt all the time. Lower socioeconomic status, lower education, those type of things, obviously, mostly because those are the people that usually hold, not mostly, but a lot of times those are the people that hold the more manual labor jobs and things, so you're going to see it in that population of people more. Smoking status, just like everything else, you know, your patients come in, and oh yeah, this is another good one, so your patients come in and you know, you get one more thing to harp at them because they smoke. So, you know, and they will look at you and roll their eyes and do everything. But 3 insurance companies now, Aetna, United, and some Blue Cross and Blue Shields, particularly the Blue Cross and Blue Shield Advantage program, which is the Medicare replacement program thing that's going on, will not authorize a spinal surgery without documented 6 weeks, no smoking, and nicotine tests. So now, here's the scary part is they don't care what they do after surgery, which is really the important time of being not smoking is after surgery and recovery than it is before. But they will do it. Also, a lot of work comp's doing it. So we've had a lot of work comp be denied until we can document nicotine-free for 6 weeks and negative nicotine tests on their thing. So that's a good thing as somebody in primary care that has a patient that comes through and they have something that's going on. Obviously if it's an emergency, it's there, but I mean, we're talking about, elective spinal surgeries, and you see somebody that's smoking, there's no reason to send them to the surgeon until you are, already working on getting their smoking status taken care of and doing all that kind of stuff. Because most of the time, we send them back to their primary care and just say, look, your insurance company says that you have to quit smoking for 6 weeks and you have to document it. We let the primary care do it. So from that standpoint, those are the things that we have to worry about with regards to this. When you're looking at impact on society, number one work comp claim is spine injuries. We probably see, and we are not big work comp people, one, because we hate work comp. People who file work comp claims, as a general, don't really want to go back to work. Now, there are the exceptions to the few that do very well and they want to go back, but a lot of them will take that time off as long as they possibly can, and you've got to see them every 4 weeks, and I mean, it gets to be a real hassle. Work comp pays well, but the patients are very hard to deal with. But number one work-related thing, number one reason why people file permanent disability claims, number two reason of missed work days. So, high impact to society, high impact to everything that's going on. Everything always goes back to anatomy. I hated anatomy, but everything goes right back to it again. And with spine pain, the more you know about normal anatomy, the more you will understand what's wrong with the patient. So many people rely on imaging studies, and you can't do that. You just can't do it. Remember when the radiologist looks at the MRI and gives you back a report to the MRI? That radiologist has never seen the patient, they've never talked to the patient, most of them, because they read it remotely and stuff. They've never seen the patient, never talked to the patient, never examined the patient, have never done anything to the patient. So all they're doing is looking at a blank picture on a thing and just telling you what the picture shows. If the picture doesn't match what the patient's complaining about or what your physical exam shows, fixing the picture is not going to fix the patient. That's why people fail back surgery. Because somebody looked at a picture and said, oh, this is bad, we've got to fix it. But the symptoms of the patient or the complaint of the patient had nothing to do with what that picture showed. So knowing the normal anatomy, taking a good history, taking that history and moving it to your physical exam that has a good physical exam associated with it. And then if you can't fix the patient conservatively or through management issues, you can't figure out what's wrong, and you want to get an imaging study to see if what you think really is there, then get the imaging. Look at the imaging, see what's going on, does it match? If the imaging matches to the physical exam, which matches to the complaint, then you send them to a surgeon or to a pain management doctor or something, and you specifically go after what's going on. But don't do it before you know what's going on. Just briefly, normal anatomy of the spine, just cervical, 7 vertebrae, goes into what we call normal cervical lordosis. You go into the thoracic spine, which then is 12 vertebrae, goes into kyphosis. So then from a standpoint is you go into the lumbar vertebrae, which has 4 vertebrae, which then goes back into lordosis again. Sacrum, which is a fused area. Don't forget the sacroiliac joints joining into the ilium, so there'll be things that we talk about that can cause pain that's not even related to the spine at all. from that standpoint. Then down into the coccyx region, which again are fused vertebrae, commonly fractured, not a lot you can do with them. So, you know, I wouldn't suggest sending somebody to a surgeon for a coccyx fracture because there's very few that will operate on them. So, you know, from that standpoint, knowing what the normal anatomy looks like then allows you to, even on a plain x-ray, get something and go, you know, oh, wow, this looks really different. The patient's scoliotic, or they have severe kyphosis, or they've got loss of lordosis or flat back, or they've got loss of lordosis or a straight neck. Those type of things are things that can lead you to believe of like, oh, okay, well maybe there's an issue going on in that part of the spine and we've got to evaluate it a little bit more. So knowing what your normal anatomy looks like helps you really understand what abnormal looks like. Then even breaking it down even further, lots of areas that we worry about. You know, obviously we start out spinous process. If we have to look at it, start out spinous process here. Common site of fractures in spine. I mean, a lot of people, they fall and hit their back straight on something if they're thin, or you know, even if they're not, but they have enough force, they can have a spinous process fracture. Those aren't any big deal. The big deal comes from a standpoint where there are inter and supraspinous fracture, supraspinous ligaments that are between those spinous processes. And if you have disruption in that ligament, that's when you can have problems, because that's when you can have instability. That's when we're really looking for the fact of, you know, that cervical fracture that came through that on CT, really on the bone, it didn't really look that bad. The patient's having this horrible pain and things are going on, and you get an MRI and find out that there's a lot of ligament damage that's sitting in between those. You know, that's when we can have a lot of danger and a lot of problems with regards to that. What else are we looking at here? Lamina, process between the spinous processes and the transverse process. Not really that important. Transverse processes, again, lots of fractures out in the transverse process. You'll get a lot of people of car accidents or whatever that have, you know, they come into you and they were like, oh, I've seen in the ER this weekend and I have a broken back. Okay, you look at the X-rays or the CT scan and you find out that they have 3 or 4 transverse process fractures. I'm sorry. I mean, nothing really you can do. You can brace those people. You can use anti-inflammatories, but surgically wise, there's really nothing that's going on. Facet, that's this thing that sits right here, or this thing that sits right over here. Facet is where one bone connects to the other. So you have a superior and an inferior facet, and they both, that's where those two vertebral bodies will actually lock into one another. Lots of pain come out of the facets. So we see lots of issues with regards to facet. I try to explain to patients it's kind of like your knuckle. So, you know, and if you start having some degenerative changes, you start getting a lot of arthritis. And where does arthritis usually accumulate first? It's going to accumulate in joints and knuckles and stuff. And so that's where we see a lot of joint effusions. In the facet joints, we see joint hypertrophy. So we see a lot of issues that are going on in the facet, and we'll talk about some of the things that we can do for facet pain. The area between the facet and the pedicle is just a very small little area that runs in there, and it's really kind of hard to tell in here. It kind of runs right behind that facet. Is an area called the pars articularis. The pars is a very common site of fracture in spine. It's called a pars defect. You'll hear about it a lot of times. It can happen in 2 different ways. You can have what's called a spondylolysis, which just means that there's a fracture in that pars, but there's no disruption. There's nothing that's going to happen. The bones are still lined up. Everything looks good. You can also have what's called a spondylolisthesis, and we'll talk about it a little bit more a little later. And that's where actually that pars has allowed those bones to actually separate from one another, and that we don't have that normal alignment again. And that can be really important. That can be idiopathic, in other words, you can be born like that. It can be caused by absolutely nothing at all, or it can be traumatic. We see a lot of traumatic in sports injuries and stuff. You know, I always tell people it's not the going forward that hurts you, it's that rapid stop at the end that does it. So a lot of car accidents, you get your seatbelt on, You know, you hit something, it goes from 60 to 0. If you've survived everything else and the seatbelt caught a hold of you, you can have that rapid jar, and that rapid movement a lot of times will cause pars defects. So from there, something to really watch. Good to see in x-ray. It's very easy to see in an x-ray. You really don't need anything else sometimes other than an x-ray to look at that. So, which is a really easy imaging thing. Pedicle, that's the area here. That's where what we call the posterior elements of the spine connect to the anterior elements of the spine. So it's what basically has it in a full unit. Obviously, the actual vertebral body itself, a lot of things can happen to it. We'll talk about the discs. Basically, what I tell my patients are shock absorbers that sit in between the spine. A lot of things that can happen to discs. So we'll talk about kind of disc pathology and things to look for discs. The thing to remember in the spine, always to remember, is the fact that where the nerves are, the good news is it's totally surrounded in bone, so it's well protected. Your spinal cord and your spinal nerves are well protected. The intervertebral foramina, where each individual peripheral nerve root comes out, is also completely surrounded in bone and ligaments. So very good, because you've got good protection of your spine. The bad part about it is if anything invades that territory where it's completely enclosed in, now the spine or the nerve roots have no place to go, and then that's where we get compression, and that's where we start to worry about things. Also, lots of ligaments in there, so you know, obviously the ligaments between the spinous processes, the transverse processes, ligament flavum, which is the ligament that's, you know, lines up right behind the posterior elements. You'll see a lot of reports and stuff that call about ligamentum flavum hypertrophy, and we'll talk a little bit about that, but just think about it as that ligament gets thicker in that area that's already enclosed, that area now just keeps getting smaller and smaller and smaller, which leads to a lot of stenosis. You have a posterior longitudinal ligament that sits behind the vertebral bodies here, and an anterior longitudinal ligament that sits in front of the bodies. Again, when we talk about fractures and stuff like that, we have to look at those ligaments, because a lot of times those ligaments are the ones that we're most concerned about, is how well will the patient heal. If you have a lot of ligament damage, then there's a good chance that the patient isn't going to heal very well, and that patient may need a cervical fusion or a spinal fusion to prevent them from having, you know, further cord issues or further problems. So looking at the ligaments can be a thing that we need to look at. The next picture, I'm not really going to go through things other than just to remind you on how important dermatomes are. Again, in your physical exam, you know, mapping out which dermatome looks to be affected and maybe what your plain x-ray looks like and what the patient's complaints are and what your physical exam is, and knowing your dermatome, you may leave something that you probably wouldn't even need. Your MRI is just there to confirm what you've already diagnosed. It's not going to teach you anything other than more than to give you a pat on the back and say, look, you were right, because everything led up to believe that it was a C6 nerve root compression, because you knew what dermatomes it were, you knew what deep tendon reflexes to look at, you knew what muscles it affected, and you knew the distribution of the pain, and so you were just able to figure it out. The one thing that I can stress, well, a couple things that I can stress in this picture. One is that if people are complaining of pain that comes down in between their shoulder blades, so you got pain from here to here, I can't tell you the number of times that people come in and they've got pain right in that area, and the primary care provider has ordered a thoracic MRI because it's in the thoracic spine. No, it's not. That's cervical. That's where the dermatomes go from a cervical standpoint. So 4, 5, 6, and 7 are going to run right back between the shoulder blades. Muscles of attachment are going to attach at the occiput, come down in and attach subscapular, and that's where they're feeling the pain from. So if that's going on, be more thinking about what more likelihood something's happening in their neck than in their thoracic spine. Remember, your thoracic spine is connected to your ribs, which is connected to your sternum. The discs are, you know, this big. So the likelihood of having a severe disc herniation or something that's causing things big time in the thoracic area is pretty low. You've got 2 areas of your spine that will move pretty much independently in the cervical and lumbar part. So think there first before you start thinking about what's going on in the thoracic spine. Also remember that because of the nerves follow the ribs, okay, and as the ribs come out of the spine, they come out, what do? They come out and they curve and they head down, okay? So T4 is nipple line. T10 is belly button, umbilicus, okay? So even though T10 structure, the bone may be up here, the nerve goes here, okay? So remember where your nerves go so that you can then be more proficient about what you're ordering. I probably get in clinic with 20 or 30 new patients a day. I bet we get 15% of them at least that come in with MRIs of CT and L. You know, they came in with back pain to their primary care doctor. Their primary care doctor did nothing, but somehow they got an MRI authorized. And so because they really didn't know where it was, they ordered just scan their spine. Well, MRIs are at best $1,800 for each level. So as you go C-spine, T-spine, and L-spine, look at how much money, one, you've cost the patient, because if they have to pay 80/20, and two, how much you've cost the insurance companies with regards to going on. So you know, the better off you can be to diagnose, the better off everybody else is. So know your dermatomes, know where things are. Again, not going to go through this because you guys all know it with regards to what's going on, but you know where your dermatome, know where your root goes, know what muscle it affects, know where sensation is, so you know where they should be having their radicular symptoms, know where their reflexes are. So obviously, you know, reflexes, if you're sitting at a normal at 2+, well, if they're at 1+, you've got some reduction in the reflexes going there. They're just not going through as quickly. There must be some disruption in that nerve root as that nerve root's trying to communicate to that muscle, and so something's going on. In contrast, if it's up and you got 3+ reflexes, then you're going to start worried about the central nervous system. Is there something compressing the spinal cord? Is there something going on in the brain? Is there something happening there? So, but knowing where those are really going to help you decipher where you need to go. Hand grip, the C8, intrinsic muscles, okay, are T1. C7, T1 is a very common area to herniate, but it is a bugger to do surgery. So, you know, just kind of know that in those, unless there's something really bad, you're starting to see a lot of atrophy in the hands. Try to do as much conservative as you can, because those surgeries, one, are not easy to do, two, not easy to recover. When you're going into T1, you know, you're sitting below the clavicular line, and that lung is just sitting there staring at you the whole time. So good way to get a pneumothorax in a C7, T1, so the risks of the surgery go up pretty high. This is just the lumbar. So, you know, like I said before, you know, I kind of skipped the thoracic region. You know, well, why do I ignore the thoracic region? Well, I don't ignore it, but people have thoracic pain, but there's not usually a heck of a lot you can do with it. Doing surgery in a thoracic spine, unless it's a Scully type scenario, but doing surgery, most surgeries in a thoracic spine, you know, typically leave the patient to the ICU. A lot of times they have chest tubes in because you're having to deal intrathoracically, and it can be, you know, it's a big surgery. So unless somebody's, you know, come in the ER with a bad car accident and you know, we've got paralysis or something that's going on into the thoracic spine, we try our best to avoid that region whatsoever. Big things to watch for, and we'll talk a little bit more later. One is you know, heel walk and toe walk. So dorsiflexion weakness, the ability to pick up your foot, is typically an L4 or an L5 deal. It's somewhere sitting in an L4, L5 region. And we'll talk foot drop. An acute foot drop is something that you've got to deal with. Get them out of your office right now and get them to a surgeon. If you can't get them to a surgeon, get them to some place where you can even get them into an emergency room situation that they can get a consult into a surgeon. If you don't fix a foot drop quickly, it's not coming back. So you've got to relieve what's going on. So if somebody comes in and they've got this acute onset of foot drop, you need to work that up very quickly. Don't sit say, well, we've got to work on some anti-inflammatories, and we've got to do some conservative therapy, and we've got to do some physical therapy. Start getting them worked up. History, I mean, you can't ever talk about history enough. I don't even know what more to say. Usually, duration, acute's usually looking at less than a month. Subacute looks between 1 and 3 months. Chronic is greater than 3 months of pain. So, if somebody comes in and tells you, that, or, you get a, I've had chronic trouble with this, and they tell you it's been going on for a couple of weeks. A couple of weeks is not chronic, it's acute. We've got to figure out what we can do to try to calm it down and make it better. But your history can be some of the best things that you do, particularly people have previous histories. So, you're going to have to, we'll talk about red flags in a minute. You're going to have to think in that previous history, is there something that's leading me to thinking that there's a red flag issue that I got to jump on this right now. Also, if they're having any kind of extremity pain, at that point in time, they're having radicular symptoms. So they're having nerve root compression. So that has to be dealt with a little faster and a little bit more aggressively than someone who's just comes in because they have a muscle strain. Right? So if they come in and says, my back hurts, but then you start talking to them and they're like, well, I keep getting these shooting pains down my leg, then it's not just low back pain, and you may have to work it out a little bit more. Speaking of red flags, these are things that you can't miss. There's stuff that you've got to look for. I put advanced age on here, but it's not even advanced age. It's extreme, it's extreme ages. We said that this usually happens in somebody who's, 40s to 60s. Well, you got a 90-year-old who comes in who's never had back pain a day in their life, and now they have back pain overnight. Something's wrong. I mean, it is not just degenerative problem and, oh, it's okay, you need to go home. Something's the matter. If they've never had back pain before and they're 90 years old, something's the matter. Same thing with kiddos. They can have the typical growing pains and my legs ache and my legs are sore, but kids don't usually have spine pain. There's really no reason for it. So you have to think, and even in kiddos, is there something that's going on? Obviously, the little old lady, you get this little 4'11", 70-pound soaking wet, hunched over, osteoporotic, sweet grandma that comes in, and now she has acute onset of back pain. Better be looking for a compression fracture someplace, because she doesn't have to fall. There doesn't have to be a trauma. She can sneeze and have compression fractures. So be thinking about that. Infection. Somebody comes in with fever, somebody comes in with a recent infection, and now they have this severe back pain. Never had back pain before, but oh my God, it's, debilitating back pain. History of IV drug use. Those type of things you have to start thinking about infection. So, do they have an epidural abscess that's going on? Do they have osteomyelitis? Do they have discitis? Do they have something where that infection has traveled, particularly in your IV drug users? You'll see it all the time. That seems to be the #1 place where blood infections love to go to. So you'll see those all the time. Some of them don't need surgery, they don't need anything, but boy, they need a PICC line and 6 weeks of IV antibiotics. And now you have an IV drug user that you just put out on the street with PICC line. So, it comes into a little challenge with regards there. Obviously trauma, unless you're working in the ER, you probably won't see this that much unless somebody's had a car accident and, it's kind of taken 2 or 3 days to the pain starts to hurt. And now they decide instead of going to the emergency room, they come to their primary care doctor, or they show up in an urgent care because things are going on. So if there's a recent trauma, that may be something that you've got to look at faster, because it's their fractures. They may even gone to the ER, and the ER didn't show up any fractures initially on the bad X-ray that they had, but now you get a CT scan or you get a follow-up X-ray, and now the fracture lines are showing. And it looks like there could be some instability. You get an MRI and you've got ligament instability, and you have a patient that's been walking around with a neck that's about ready to fall off. So watching those things. Bowel or bladder, saddle anesthesia, that is, huh? I heard it. Cauda equina syndrome. Another one of those kind of spinal emergencies. Somebody comes into the ER and they said, oh, you know, my back, I really haven't had any problem, but all of a sudden now I've got weakness in my lower legs, my back is hurting. Their back may not even hurt, but I've got weakness in my lower legs, I'm having bowel or bladder issues, or I'm having saddle anesthesia. You better be getting an MRI quick, because if they have saddle anesthesia, if they have that and we don't do surgery, again, you may not get that bowel and bladder function back fairly quickly. So that's something that has to be dealt with fast. Then obviously the last thing, history of cancer. You know, somebody who had breast cancer 10 years ago and said, you know, oh, I've been cancer-free, blah, 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 blah. All of a sudden now I'm having this horrible spine pain. Breast is a big one that goes to spine. And you get a X-ray, sometimes they'll show if it's a big lytic lesion, but you get a CT scan and you're going to see mets probably throughout the spine. Weight loss, again, you know, I haven't been trying to lose weight, but in the last couple of months I've lost 20 pounds, and I don't know why. You know, they're thinking, is there cancer someplace I need to look at? Imaging studies to look at while you're looking at it. X-rays. Best thing you can do if you get a red flag, the fastest thing you can get them in is somebody get an X-ray on them pretty quick. I mean, it shouldn't be hard to be able to get X-rays. And that at least is going to give you a place to start. Of course, then if you have somebody that comes in and you've been seeing them for 6 or 8 weeks, and you've been trying to treat this muscle strain for a while and it's just not getting any better, then you might want to go get an X-ray. You know, is there something else that you may be missing? Gross abnormalities on exam, like I said, normally X-rays are fairly easy to get. They're cheap. So that's the first place I go to. The rest of them, when you look at MRI, CT, and CT myelogram, it just kind of depends on what you're looking for. You know, if you're looking for bony issues and you're looking for problems with regards to the bone, trauma, cancer, you know, CT is usually the way to go. It's cheaper, it's easier to get, it's more places that you can get it faster. If somebody can't get an MRI, you know, they've got a pacemaker, or they've got a spinal cord stimulator, or they've got aneurysmal clips in that were put in years and years and years ago that you have no idea what they are, get a CT scan on those people first. Take a look at it. You can usually tell pretty much anything you want to know from a CT scan. You can see it better on an MRI, but you can usually do okay on a CT scan. If it's the only thing you got, get it, because at least it'll give you the information that you need. MRIs, again, with or without contrast. Don't order everything with contrast. Again, you're just doubling the cost to the patient. You're increasing their risk of kidney issues because of contrast material. They have to get lab before they have contrast. So, but if they've had, you know, if they've had hardware put in there and you know that that hardware is going to give artifact, contrast may be the only thing that'll help you with regards to what's going on from there. If you think that's infection or you think that it's cancer, getting it contrasted is probably a good idea too, because you can get more information from contrasted MRI. CT myelogram, obviously, we order very few of these. Your patients will hate you if you get a CT myelogram, okay? Likelihood that they're going to get a small CSF leak, they're going to have dural headache, you know, they hurt. So if you have to get a CT myelogram for something, order one, but if you're not, I tell people the time to get a CT myelogram, one, is if you order a CT scan and the radiologist comes back and says, look, we're having a really difficult time seeing this, we need to get a myelogram. Okay, maybe I would go with it for there. Or two, refer them to either the neurologist or a neurosurgeon or an orthopedic spine surgeon. Let them make that decision. Let the patient hate them, not you. But CT myelograms are not fun. They're no fun to do either. So when we look at back pain, basically what we look at is the fact that we can split it up into several categories. Non-specific back pain is going to be the biggest junk that you'll see. So more than 3/4 of the patients will probably have just kind of this non-specific stuff, okay? The thing is you gotta remember, a majority of them are coming in with non-specific, but don't forget your red flags. So get your history, know what's going on, so that you can rule out all those mean, bad elephants, and then you can deal with cervical strains, lumbar strains, you know, those type of issues, which are just gonna be done with conservative therapy. I mean, you're not gonna do surgery for whiplash unless there's ligament problems or fractures or things that you see later. Whiplashes, forewarn your patients from a standpoint, it could be 6 months before, or more, before they're feeling better, okay? They may have chronic headaches, they may have trouble concentrating, they may have troubles, you know, with lots of things that are going on, and it can last a long time. So kind of following them and making sure that they're having at least some progression, things are getting a little bit better, is important, but just because they come in and say, I don't get it, it's been 3 months, why do I still feel bad? They're gonna. If you get a bad enough whiplash injury, they're gonna feel bad for a long time. Most of these you'll find are almost always musculoskeletal. They're axial symptoms. I hurt, you know, along my spine. You can't ever find anything radicular. Your physical exam, their deep tendon reflexes, their sensation, everything is normal. So those patients, treat conservatively for a while and just kind of see how things go. When you're looking at these patients, basically, they'll talk to you, they'll tell you it's a sharp pain. You know, it feels like somebody's just stabbing, they got an ice pick right there, you know, and they can usually point to it, and it's typically sitting down in one of the things. They get pain with movement, but the hard part is not to tell, you know, it used to be ages ago, what did you tell? Somebody came in with back pain, oh, go rest for the next 3 to 5 days and lay around in bed and don't do anything and eventually it'll get better. No, that is the worst thing you can do. So light stretching exercises, constant movement, getting up, walking around, doing things with regards to getting stretching and getting things moving. It hurts with movement, but you'll find is that if they do it, if they stretch and they do it more frequently, it actually feels better. So if they're just laying there in bed, they'll get stiff and sore and all that kind of stuff. They'll get up and start to walk and it'll hurt, but the minute they really start moving and getting things going, it actually feels better. Decreased range of motion, obviously, you know, they're not going to touch their chin to their chest for you, but if you start getting them to slowly start working on their range of motion and do some good stretching exercises, that's gonna calm down a lot. I always use the analogy, if you get a calf cramp in the middle of the night and you're laying in bed, you don't just lay there and wait for it to go away. I mean, the first thing you do is you're bouncing out of bed, you're walking around on it, you're rubbing it, you're doing whatever you can to get that muscle to release. There's no difference in calf cramp as there is in a paraspinous cramp. So you're gonna treat it the same way. Obviously, medications, NSAIDs, definitely, okay? Don't even hesitate unless, you know, they have some bad peptic ulcer stuff or they've got some horrible kidney issues, and then you're kind of screwed. But muscle relaxants, temporarily, don't send them home with 90 muscle relaxants, you know, 15, 20, 25. Have them take them sparingly, see if they can, mostly at night, have them take them at bedtime, see if they can get their muscles to relax enough at bed to get some sleep to allow the muscles to heal and regenerate. Narcotics, they're not indicated in spine pain. You know, at first I was mad as a hornet when they took away our hydrocodone prescription rights. Now it's the happiest day of my life. I mean, I love it from a standpoint because people come in and they're like, you know, oh, I've got low back pain and I need pain pills. No, you don't. You don't need pain pills. And the good news is I can't write them for you anyway, so therefore you're good to go. You know, maybe a little tramadol, for a couple of days to appease them or whatever, but they don't need narcotics. Don't give them narcotics. What else? Steroids, conflicting. Okay, the evidence-based studies will tell you steroids do nothing for muscle strain and you shouldn't use them. Okay? We use them all the time. I use them every day. Okay? The majority of the time patients feel better faster. And if you can get them if you can get a little bit of, you know, anti-inflammatory, you know, a strong anti-inflammatory on board and get them to feel better faster, then they go away. okay? Don't let them take steroids and NSAIDs at the same time, they'll tear up their stomachs. And then obviously conservative, put them in a brace if you need to, put them in a soft cervical collar, don't tell them to wear it all the time, just wear it intermittently with regards to what's going on, heat or ice, TENS units, physical therapy, traction feels good while they're in it, but it turn around and come back afterwards. So chiropractor, acupuncture, if they're neurologically not having an issue, I really don't have an issue with a lot of chiropractors. As long as you develop a relationship with a chiropractor that knows how to do a physical exam, actually does a physical exam before they work on a patient, looks at x-rays or at least even talks about x-rays from a standpoint. Have you had x-rays on your spine? What's going on? Maybe we should get an x-ray and take a look at it and see what's happening. So at least you know that they're kind of paying attention to what's going on. It's not just somebody that's putting up a side street that just comes in and snap, cracks, and pops you and then sends you home and then finds out that you've got a bad disc herniation and now they've made it worse and now you have Cotter-Klein syndrome. So as long as you have somebody that you feel confident with, I don't have a problem. So we have non-mechanical, now we have mechanical. Mechanical is actually a disruption in something that's going on in the spine. That's again about a quarter, a third of these patients that you'll see that's happening. Most of these now turn into kind of that chronic patient, unless it's something that's a traumatic or something that's happened immediately. Most of these are chronic. These are people who've had pain for months and years. Now they may have had an exacerbation of pain. They've done something that has caused an acute onset on something that's already chronic. So we have to kind of continue to look at those. These will tend to run in these kind of categories. So degenerative, something that's occurred over a long time. Congenital, something they were born with. A herniated or a bulging disc that we'll talk about. Spinal stenosis, which is just a little bit more than just the herniated disc. And obviously your fractures. Risk factors with regards to degeneration, obviously this is where age comes in. Remember we just said it was a progressive disease. It's something that happens over a long period of time, so that the older you are, the worse it probably gets. Smoking history, again, it not only, and you'll hear a lot from Heather today when she comes in, she runs our bone health program, which is really good. You'll hear a lot probably from her about smoking as far as the reversal in osteoclast to osteoblast. So a lot of bone issues with regards to it. We also know that it has a lot of dehydration issues with regards to nicotine and tobacco and smoke. So a lot of the dehydration things that we see in an MRI will also lead to smoking. Family history, mom, dad, brothers and sisters. Oh, my entire family has back pain. Yeah, there's a good chance you're going to get it too. Sports, the more sports you do, the more contact that you have, the more labor that you do, the fatter that you are, the more likelihood that you're going to have these issues and they're going to progress a little bit faster. Things that we can look at in this, is it just discogenic pain? Is it just axial? Is there really a lot of times no radicular symptoms to it? Is it just in the disc itself? Is that disc dehydrated? That L5S1 disc right there, this is a T2 image on an MRI. So this is the sacrum here, and we go up 5, 4, 3, 2, 1 from this. These are reasonable discs. So in a lumbar spine, you should see this. So we talked about the thoracic disc not looking like much. That's not an abnormal disc. That's what a normal thoracic disc looks like. So people come in and say, oh, well, they've got severe degeneration in their thoracic spine. Oh, I know. That's what they all look like. There's just really not that much disc material there. But this one obviously has got some degenerative issues to it. There's no fluid in it. So you've got to start thinking about the fact of, we got a lot of annular tears in there. Do we have fissures? What do we have going on that's creating them to have back pain? Spondylosis, basically a longer acting degenerative problem, so that degenerative disc that's there has now resulted in the fact that those bones are, as patients love to call it, on bone, where the bones collapse down against one another, and as they collapse down against one another, they start to have reactive changes in the end plates of the bones itself. You'll see that in an MRI. It just means it doesn't mean that there's an infection there. It just means that it's been there for a long time. And so you see it. Also, we start seeing a lot of what we call posterior element disease. So we talked about that ligament of flavum hypertrophy. We talked about facet hypertrophy, getting big old knuckles sitting back there in the back of their spine that not only block the central canal, but also block the foramen as the neuroforamen is trying to get out. So that facet sitting in there causing irritation to what's going on. Spondylolysis we talked about a little bit ago. That's a Pars defect, but you're not having separation of the bone. And spondylolisthesis is where you actually have the bones that don't line up anymore. So bones, instead of it looking like this, will now look like this. The important part about this is, one, it's graded, and we'll talk about the grading later, but two, if you see this on a normal x-ray, the next x-ray you have to order now is get 2 more views on them and do them in flexion and extension. So when they go into flexion, does it go more? When they go into extension, does it correct? If it does, then you have what's called a dynamic spondylolisthesis, and that, there's not a pain management treatment out there that's going to fix that. I mean, if it gets bad enough, the only thing that will fix it is a fusion to get that back and get that pulled up. Okay. The other thing you have to watch with the dynamic is the fact that you send them to the Laser Spine Institute or you send them someplace that's just going to do a little laminectomy on them. Well, they're already mobile, and now you remove a bunch of bone away from it, and now you're going to have a grade 2 spondy that turns into a grade 4 spondy overnight. So be careful with spondies. Quickly, because we just already talked about spondy, this is what a spondy typically will look like. So spondylolysis is over here. Remember the whole Scotty dog thing on the x-ray? Can you see that? So here's the ear right there, and there's the nose. This is the facet joint that's right here. It should look like this, where there's this straight line that goes right through that facet joint. Here's the eye. Actually, this looks like a better Scotty dog. So here's the eye, here's the ear. But this is the facet line here, and you look up here, that line is broken. So as that line comes down, and then kind of blocks over. Everybody look at clouds? So from the standpoint, this is what we're looking at, but the bone looks like it's lined up, everything's going okay. This is a spondylolisthesis. So it's got that separation that's right there where the back end of this bone doesn't line up with the back end of that bone. And that's what we're looking for when we look at a spondy. Typically, L4-5 and L5-S1, number 1 and number 2 places to find spondylolisthesis. You don't usually find them up higher than that. You can, but those are the 2 most common. Treatment, obviously, smoking cessation, particularly now with insurance companies telling you can't do anything until they quit smoking. Weight loss, I mean, it's hard. How are you going to lose weight? Well, when are you going to stop eating until you're going to exercise? But if these people hurt so bad that they can't exercise, then you're kind of in a double-edged sword. So getting them into some aquatic therapy, if you can get them into getting into a pool and doing a little water walking, doing things, anything to encourage them to start the weight loss process before you try to do the surgery, so that after they have the surgery, they're at least in the mind frame to continue the weight loss. Okay. Core strengthening, horribly important. I have all my patients doing yoga, Pilates, those type of things, anything that affects your core. Stability balls, if they're at work and their back hurts all the time, I tell them go get a stability chair, or work on your company to get you things that are going to kind of help support that with regards. But real important, low impact exercises. If they're hurting and they need to lose weight, don't tell them that they need to go out and start running 5Ks, because then they're just going to hurt worse. So, start slow, work their way up. Bracing, I'm here nor there on bracing. Try them. If it, helps and they feel better with it, then that's fine. But remember, if they're in a brace all the time, they're not utilizing their muscles. So you're going to make them weaker if they're in it all the time. So encourage them that they can be in it on occasion, but you don't want them in it all the time. Chiropractic, acupuncture, physical therapy, we talked about all those later. NSAIDs, first line of therapy. Pain management, lots of things that you can do with pain management nowadays. I mean, huge boom in that business, and a lot of times those are things, particularly things like this new stem cell stuff that's coming out, the IDETs, which are, come here, come there, depends on kind of the hand of the person that has it in. If you can find a good pain management doctor, particularly if you can find one that also likes to do pain medicine, good luck. Keep them, don't make them mad, buy them lunch, do whatever you need to do to keep them in your good side, because pain management doctors are very hard to come by. Also, you can really help your pain management doctors nowadays because encouraging your patients that it is extremely hard to get one of these doctors, and if you do one thing wrong, they're going to fire your butt. So a lot of times you have a better rapport with your, if it's primary care or whatever, you have a better rapport with your patients. And I go in and talk to my patients all the time and say, look, we're gonna send you to pain management. But it's not only gonna look bad on you if you mess up, it's gonna look bad on me too. So, you know, here's the deal. I need you to stay up front with them. If you go in and you've taken your medicines the wrong way and you've done it wrong, don't lie, because they're gonna run a test, they're gonna run a urine test that's gonna look at concentrations, and they're gonna know if you've been not taking it, then they're gonna accuse you of selling it, or you've been taking too much and not taking the way it's prescribed. So if you go in and you've done something wrong, it better be like going into the principal's office and saying, I did it, you know, I did it, I'm sorry, I'll never do it again, you know, please don't fire me, kind of thing. Don't get defensive, because the minute they get defensive, I can guarantee you that pain management doctor is going to send them right out the door. Because there's too many that are getting their license revoked and removed. Now, they may need to, I mean, they may legitimately need to have that done, but the ones that are good are really sitting on a hot zone right now, and so they're being watched so closely that you have to help support them. So, you know, you need to be just as hard on your patients as the pain management doctor is, because they may listen to you more than that they'll listen to them, because they know you better. So be there with them. Surgery, obviously, there's a lot of hubbub, artificial disc replacement, motion preservation disc replacement, basically what we're talking about. Lumbar spine, I don't like it. It doesn't do well usually. Remember, a spine hurts when it doesn't move, and it hurts when it moves too much. What we found out in most of the lumbar ones currently that are on the market is you get hypermobility, and you can get adjacent disc problems above and below the level of the replacement itself. And you also get pain with it because you get hypermobility. Cervical spine in single levels, sometimes even in 2 levels, have been showing better results, but I think it's because they have less stress. You know, your cervical spine doesn't have as much movement as your lumbar spine. It doesn't carry as much weight as your lumbar spine. It doesn't have as much effect in the cervical. You know, it doesn't have the impact if you're back into exercising and stuff. So cervical spine, it's, you know, it's done well. Arthroplasty's done well. Lumbar spine, it hasn't done as well. Obviously, you know, foraminotomies, laminectomies, fusion surgeries, and we'll talk about different kinds of ones with regards, but you know, everybody has a different problem and they have a different reason to have a different surgery. We'll go into congenital. This is really quick. Really, when you're talking about congenital, we're looking at kyphosis or scoliosis. Kyphosis, we really have to watch for in the little old ladies that are having multiple wedge compression fractures. So, you know, the back part of the bone is like this, and the front part of the bone collapses down with regards, and what that does is automatically create a kyphotic deformity that will start to occur. Most of these will occur kind of in that thoracolumbar junction and all the way up into the thorax. So this is time where you really start to look at what's going on in the thorax. Boosting those up with kyphoplasties or vertebroplasties, putting them in braces, putting them in physical therapy. Not usually doing surgery on them because it's an getting them to a bone, getting them to Heather for a bone health evaluation, getting them on the right medication to kind of help start building their bone structure so that they'll quit forming those. So those are usually, unless it's a congenital thing where you were born that way, is usually associated with most of the degenerative stuff. Also, scoliosis, you know, usually affects the 2 spectrums. So, you know, you've got kiddos that will be born with a congenital scoliosis. Surgery off and on in those, but you've got to look. If they're having a rapidly progressive scoliotic curvature and they're still in their developing ages, so they're still, you know, where they're still in growth, you're going to start worrying about, you know, lung maturation and lung, you know, organ growth and organ maturation and making sure that everything's okay. Also, just their overall perspective of life. You know, if they walk around all, you know, crumpled over from the age of 8 on, you know, those people need to go, those kiddos need to be evaluated by a pediatric orthopedic surgeon No, we'll usually follow them for a year, for a couple of years, just to kind of see, usually see them about every 6 months, and see if we're having progression. If we do, then we've got to think about surgery. But getting those patients over to an orthopedic surgeon to really kind of watch for them and watch those. Also, in your adult ages, as you start getting all those degenerative changes that are just aren't in the lumbar spine, and they don't really have, most of them just have low back pain. A lot of them don't have any radicular symptoms associated with it, but boy, they just keep falling over and falling over and falling over. We do a lot of degenerative adult scully stuff. And you think, I mean, look at all that hardware. That's actually one of our patients. You look at all that hardware that's sitting in there and you think, oh my God, how in the world does that patient, do well after surgery? These people are amazing. 2 days in the hospital and they're home and they're doing great. And we did one last night. It's about a 6.5 hour case. So they're fun to do. It's fun to look at. It's fun to look at like the before and after pictures on these things. It's fun to see the patient. I fuss at them all the time because they come in. They've been walking like this for so long. Okay. That even after we straighten them and they don't have to walk like that, they still come in and they're walking like this. And you're like, stand up straight. And they're like, oh, yeah, I can. Most of them will say, are you going to make me taller? And I go, yeah, because you're going to stand up straight. These are pretty, they're pretty fun patients to deal with. What we did yesterday was a nurse. She's bad. So, I mean, she got to the point where literally she had to quit working. She was like, I can't do it anymore. She could barely look up to look at you in the face. So if you were standing there, I mean, she was sitting, she was okay. Well, kind of, sort of. She kind of looked at you from the side of her face. But, her curvature had progressed so far and had dropped her ever so far that she couldn't look up and look at you. So, bulging discs, herniated discs, you'll see this all the time. These are the ones I'm saying from a standpoint that if you get an imaging study, and the imaging says, oh, he's got multiple levels of disc protrusion, multiple levels of degenerative discs. Well, if your history and your physical have not done anything to describe what's going on, then the imaging's not going to do you any good. And if you have multiple levels, you're not going to get a surgeon that's going to come in and fix 5 levels of their spine, and the patient's going to do better than what they did coming in. So use your history and your physical to define which area is important and then get your imaging on what's going on. Typically a bulging disc is a disc that stays the annulus. So remember the disc is 2 components. You got the annulus on the outside, which is cartilage, and then you've got the nucleus pulposus on the inside. So a bulge is just basically, you just squeeze that little stress ball a little too hard and it's just protruding or poking outside of the vertebral bodies itself. Okay? May not be out there all the time, may not be causing any problems, may not be affecting anything. So you may not have to do anything with a bulging disc. A herniated disc, on the other hand, the nucleus pulposus actually is outside of the annulus. So it can be causing more effect. It can be lodged in your nerve foramen. It can be lodged up against a nerve. It can be protruded. In other words, it's still connected to what's on the inside and it's just there. Or it can actually be extruded. Somebody just pinched it off and knocked a piece off that sits in there. And we see those quite a bit. Those can be treated conservatively initially to see if we can get them to behave themselves and shrink down. And a lot of times the body will, if you did, they've done studies where you've done serial MRIs on people who have just sat and watched them, and they literally just kind of shrink down to nothing and they turn into what looks like a little pebble that's sitting back there, and as long as it doesn't block anything, just leave it alone, who cares? But if the patient has persistent problems and you can't get them to get any better with conservative therapy, then you got to do something. Okay. Hammered this enough. These people are going to usually have both axial symptoms and radicular symptoms. If they're having radicular symptoms, then that means they're having nerve root compression. If they're having nerve root compression, that puts them at more likelihood of having further treatments, whether it be pain management treatments or whether it be, interventional treatments or whether it be surgical treatments. Those are the people that you have to keep following. And the reason you have to keep following is because first you have pain, based on how the nerve runs. First you have pain, then you get numbness and tingling, then you get atrophy. Okay? If you wait on them long enough till they get atrophy, and then you decide, ooh, I better get them to a surgeon because their bicep used to be this big around and now it's this big around, their bicep's never gonna be this big around again. You may